Hello, today we are going to learn about preparation and management of known difficult airway in adults. The goals of this lecture is to prepare and manage a known difficult airway, learn the indications, contraindications, and the technique of awake fiber optic intubation, learn different blocks to anesthetize the airway, and to learn the pharmacological preparation and sedation for performing an awake fiber optic intubation. The difficult airway represents a complex interaction between patient factors, the clinical setting, and the skills of the practitioner. In the setting of a difficult airway, the anesthesiologist should assess the likelihood and clinical impact of basic management problems. These problems could include a patient who is not cooperative or is unable to consent, who is a difficult mask ventilation or placement of a supraglottic airway is difficult, or is a difficult laryngoscopy and intubation, and a difficult surgical airway access. The anesthesiologist should always assess the relative merits and feasibility of basic management choices available. These include the possibility of an awake intubation versus intubation after induction of general anesthesia, non-invasive techniques versus invasive techniques for the initial approach to intubation, video-assisted laryngoscopy as an initial approach to intubation, preservation versus ablation of spontaneous ventilation. During the management of a difficult airway, the practitioner should actively pursue opportunities to deliver supplemental oxygen throughout the process of management. One should always develop a primary and an alternative strategy to manage a difficult airway. Now let us consider this clinical scenario. We have a 46-year-old patient who's 5 foot tall, weighing about 350 pounds, with a history of hypertension, hyperlipidemia, and diabetes, and is scheduled to undergo a total abdominal hysterectomy under general anesthesia. On examination, the vital signs are stable. The patient is awake and cooperative. Airway examination reveals a Mallampati 4, thyromental distance less than 2 finger breadths, and prominent upper incisors. There is a previous history of a difficult mask ventilation and difficult intubation. Based on the information available and the airway examination and previous history of difficult mask ventilation and difficult intubation, it is reasonable to secure the airway by awake fiber optic intubation. When faced with a difficult airway, awake intubation is the gold standard for airway management. Preparation begins with a careful history, a physical examination, and a detailed discussion of the procedure with the patient. Awake intubation has several advantages. The patency of the airway is maintained by pharyngeal muscle tone when the patient is awake, and spontaneous ventilation is maintained. A patient who is awake and well topicalized is easier to intubate because the larynx moves to a more anterior position after induction of anesthesia compared with the awake state. The awake patient can still protect his airway from aspiration. Now let us look at some of the indications for awake intubation. A patient with a previous history of a difficult intubation or difficult intubation and ventilation, anticipated difficult airway based on physical examination. A patient with a small mouth opening, a receding mandible or micrognathia, a macroglossia, a short muscular neck, limited range of motion of the neck in patients like rheumatoid arthritis, ankylosing spondylitis, or prior cervical fusion, congenital airway anomalies like Treacher-Collins syndrome or Pierre-Robin syndrome, morbid obesity, airway masses, malignancy of the tongue, the tonsils, a large goiter or a mediastinal mass, upper airway obstruction, an unstable cervical spine, trauma to the face or upper lip. Absolute contraindications to fiber optic intubation include patient refusal or a patient who is unable to cooperate, example, a child or an obtunded patient, or a patient with a documented true allergy to all local anesthetics. If immediate airway management is required, another technique should be used. Blood and secretions easily soil the optics of the fiber optic bronchoscopes and render the bronchoscope ineffective. Based on the history, the physical examination, the airway examination, and the past difficulty in ventilation and intubation, the safest option to intubate this patient is to consider an awake intubation, and the airway can be approached by a non-invasive intubation like an awake fiber optic intubation. Preparation for an awake intubation begins with a careful history and physical examination and a detailed discussion of the procedure, including the complications. The patient's consent must be taken, and the patient must be assured that they will be made as comfortable as possible. The anesthesiologist must evaluate each patient's needs on an individual basis. The goals of premedication are to alleviate anxiety, provide a clear and dry airway, protect against the risk of aspiration, and enable adequate topicalization. Nearly every patient experiences some degree of anxiety associated with the surgery and anesthesia. Hence, most patients require some degree of sedation and analgesia. In the setting of a difficult airway, it is best to use short-acting or reversible agents for sedation or agents that do not cause significant respiratory depression, and the dose of the drugs administered must be titrated carefully to maintain cooperation from the patient and to sustain adequate ventilation. Adequate topicalization of airway with local anesthetic is the key to successful awake intubation. If airway topicalization is insufficient, airway nerve blocks may be employed to supplement the airway anesthesia. At least one additional individual who is immediately available to serve as an assistant in difficult airway management should be available. If possible, it is preferable to have a second member of the anesthesia team who can assist in monitoring, ventilation, and to administer the drugs. A surgeon trained in performing a surgical airway should always be available with a tracheostomy or a cricothyrotomy tray. When managing a patient with a difficult airway, whenever possible, previous anesthesia records should be examined because they can provide very useful information, like the degree of difficulty of the endotracheal intubation and the method used in the past, the positioning of the patient during laryngoscopy, if a ramp was used or was the patient in sniffing position, what equipment was used in the past, and what technique was used previously. One should not attempt to learn a new technique on a difficult airway. Managing a difficult airway also includes monitoring the patient's ECG, oxygen saturation, non-invasive blood pressure, and capnography. Depending upon the patient's condition and comorbidities, invasive hemodynamic monitoring may be considered and may need to be placed prior to awake intubation. Supplemental oxygen should be administered throughout the process. Arterial hypoxemia has been well documented during bronchoscopy with an average decrease in the arterial oxygen tension of about 20 to 30 millimeters of mercury in patients breathing room air. And this hypoxemia could precipitate cardiac arrhythmias. The sedation administered to supplement topicalization may also result in unintended respiratory depression or apnea. Therefore, it is critical to provide supplemental oxygen throughout the process. A variety of airway equipment should be readily available during the management of a difficult airway, which includes different laryngoscope blades of different designs and sizes, endotracheal tubes of different sizes and styles, intubating stylets, light wands, laryngeal mask airways of different sizes and styles, such as an intubating laryngeal mask, fiber-optic intubation equipment, VD laryngoscopes like glide scopes, retrograde intubation equipment, transtracheal jet ventilation or esophageal combi tube, and equipment suitable for emergency surgical airway access must be readily available. Once a decision has been made to perform an awake intubation and the patient has agreed to proceed with the awake intubation, premedication is commonly employed to alleviate anxiety, provide a clear and dry airway, protect against the risk of aspiration, and enable adequate topicalization of the airway. The agents most commonly used for premedication are antisyllagogues like atropine, glycopyrrolate, and scopolamine, mucosal vasoconstrictors to decrease the bleeding secondary to instrumentation of the airway, H2 receptor blockades, and sedatives and hypnotics. One of the most important goals of premedication for an awake intubation is drying of the airway secretions, because secretions can obscure the view of the glottis, especially when the fiber optic bronchoscope is used. Secretions can also prevent local anesthetics from reaching the intended areas, resulting in failed sensory blockade. They can wash away and dilute the local anesthetics, thereby diminishing their potency and duration of action. Medications often used are atropine, glycopyrrolate, and scopolamine. The anticholinergics should be administered at least 30 minutes prior to topicalization to have maximum benefit. Atropine is usually used in the dose of 0.4 to 0.6 milligrams IV or IM. It has a rapid onset of action of less than a minute following intravenous administration. Glycopyrrolate 0.2 to 0.3 milligrams IV or IM has an onset of about 1 to 2 minutes after IV dosing. Scopolamine 0.4 milligrams IV has an onset of action of 5 to 10 minutes. Nasal mucosal vasoconstrictors are commonly used to decrease the vascularity of the nasal mucosa. The most commonly used vasoconstrictors are 4% cocaine, which has vasoconstrictive as well as local anesthetic effects. Combination of lidocaine and phenylephrine. And these vasoconstrictors and local anesthetics are applied with cotton swabs or pledgets to the nasal area Adequate anesthesia and vasoconstriction can be achieved in 10 to 15 minutes. Alternatively, phenylephrine 0.5% or oxymetazoline 0.05% sprays can be administered 15 minutes prior to attempting nasal intubation. Some patients requiring an awake intubation may need prophylaxis against aspiration pneumonitis. For example, patients with full stomach, symptomatic gastroesophageal reflux, hiatal hernia, morbid obesity, diabetic gastroparesis, or pregnancy. Pre-procedure administration of non-particulate antacids such as sodium citrate, H2 receptor blockers, or proton pump inhibitors help to decrease the incidence of aspiration during awake fiber optic intubation. Sedatives and hypnotics may be useful in allowing the patient to tolerate an awake fiber optic intubation by providing anxiolysis, amnesia, and analgesia. The commonly used sedatives and hypnotics include benzodiazepines, opioids, alpha-2 agonists, which can be used alone or in combination. It is important that these agents be carefully titrated to effect because oversedation can render a patient uncooperative and make the awake intubation extremely difficult. One of the goals of an awake fiber optic intubation is to maintain spontaneous respiration with adequate oxygenation and ventilation. Benzodiazepines are also used for their amnestic and anxiolytic effects when other sedatives like dexmedetomidine, ketamine, or remifentanil are chosen as the primary agent. Commonly used benzodiazepines are midazolam, diazepam, and lorazepam. Midazolam is usually used between 0.5 to 1 milligrams IV repeated until the desired level of sedation is achieved. Midazolam has a rapid onset of action, usually within 2 to 3 minutes of IV administration. The duration of action lasts about 20 to 30 minutes. The most common adverse effect of oversedation with benzodiazepines is respiratory depression, which may lead to hypoxemia or apnea. Therefore, flumazenil, a benzodiazepine antagonist, must be readily available to reverse the sedative and respiratory effects of benzodiazepine overdose if a patient becomes too heavily sedated. By way of the agonistic effect on opioid receptors in the brain and spinal cord, opioids provide analgesia, depress airway reflexes, and prevent hyperventilation associated with pain or anxiety. The commonly used opioid agents include fentanyl, sufentanil, alfentanil, and remifentanil. Remifentanil infusion rates ranging from 0.06 to 0.5 micrograms per kilogram per minute, with or without an initial bolus, is commonly employed. In the event of an overdose, naloxone is used. 0.4 or 40 micrograms to 80 micrograms IV bolus is given every 2 to 3 minutes in the event of a respiratory depression. The opioids are carefully titrated to effect, and every effort should be made to prevent any drug-induced respiratory depression. Remifentanil is an ultra-short-acting opioid which has a very short half-life. Dexmedetomidine is a centrally acting, highly selective alpha-2 adrenoreceptor agonist. It has sedative, analgesic, anxiolytic, and anti-sialagogue effects and causes minimal respiratory depression even at high doses. For an awake intubation, 1 microgram per kilogram loading dose over 10 minutes is followed by a continuous infusion 0.2 to 0.7 micrograms per kilogram per hour. Central alpha-2 mediated sympatholysis can cause bradycardia, hypotension, and decreased cardiac output with dexmedetomidine. Ketamine is another sedative hypnotic that is used in patients with difficult airway for sedation and hypnosis. It is a phencyclidine derivative and an NMDA receptor antagonist that produces dissociative anesthesia. Ketamine-induced anesthesia is associated with amnesia, nystagmus, and the potential for hallucination and other undesirable psychological reactions. Benzodiazepines are commonly administered to attenuate or treat these reactions. Dexmedetomidine has also been shown to reduce the incidence of these psychological reactions. Usual dose of ketamine for sedation range from 0.2 to 0.8 milligrams per kilogram IV. Ketamine causes increased airway secretions that can lead to upper airway obstruction or make the fiber optic intubation difficult. Therefore, patients receiving ketamine should always be pretreated with anticholinergic agents. To prepare the nose and the nasopharynx, the nasal mucosa must be vasoconstricted and anesthetized. And this is typically done using a 4% cocaine solution or a combination of lidocaine and phenylephrine. Oxymetazoline nasal spray helps to promote vasoconstriction in the nasal mucosa. Cotton-tipped swabs or pledgets soaked with the local anesthetic solutions are applied to the nasal mucosa to topicalize the airway. The oropharynx and the tongue may be topicalized by aerosolized local anesthetic or bilateral blocks of the glossopharyngeal nerve. The larynx and trachea can be anesthetized by topicalization, or nerve blocks may be used for the larynx and trachea. Local anesthetic may be sprayed, aerosolized, or nebulized into the airway. Alternatively, superior laryngeal nerve block or transtracheal injection can be performed to provide anesthesia to the airway. In most cases, topicalization of the airway should be the primary anesthetic for awake intubation for a difficult airway. Commonly used agents include lidocaine, cocaine, benzocaine, and tetracaine. Lidocaine is an amide local anesthetic, is the most commonly used agent for airway topicalization. It is available in various concentrations ranging from 1 to 10% and various forms, which include aqueous and viscous solutions, ointments, gels, and creams. 1 to 2% lidocaine is commonly used for infiltration and nerve blocks. For topical anesthesia, concentration used is between 2 to 4%. Lidocaine is an excellent choice for airway anesthesia because of its reasonably rapid onset of action, which is about 2 to 5 minutes, and has a high therapeutic index. The duration of action of lidocaine is approximately 30 to 60 minutes after topical application or infiltration. The maximum recommended dosage for infiltration of lidocaine without epinephrine is 5 milligrams per kilogram. Cocaine is a naturally occurring ester anesthetic and is primarily used for anesthesia of the nasal mucosa when a nasal intubation is planned. It is available in a 4% solution and each drop contains about 3 milligrams. The maximum recommended dosage for intranasal application is 1.5 milligrams per kilogram. Cocaine is applied to the nasal mucosa using cotton pledgets or cotton-tipped swabs. The peak plasma concentration of cocaine is achieved in 30 to 45 minutes and the drug persists in the plasma for 5 to 6 hours. Signs and symptoms of cocaine toxicity should always be looked for, which include tachycardia, cardiac arrhythmias, hypertension, and fever. Some of the severe complications of cocaine intoxication include convulsions, respiratory failure, coronary spasm, cardiac arrest, stroke, and death. Cocaine should be used with caution in patients with pre-existing conditions like hypertension, coronary artery disease, hyperthyroidism, preeclampsia, and those who take monoamino oxidase inhibitors. Benzocaine is a water-soluble ester local anesthetic which has a rapid onset of action of less than a minute, and the duration is approximately 5 to 10 minutes. It is most commonly available as a 20% aerosolized liquid in a canister. Benzocaine toxicity can manifest as methemoglobinemia, and the patients can present with cyanosis, tachycardia, and tachypnea. Treatment of methemoglobinemia involves administration of methylene blue, 1 to 2 milligrams per kilogram IV over 5 minutes. 0.5 to 1% tetracaine is used as a local anesthetic, and it has a longer duration of action than lidocaine or cocaine. Cytokine spray contains 14% benzocaine and 2% tetracaine and is often used to topicalize the oropharyngeal mucosa. For awake fiber-optic intubation, the airway can be topicalized using atomizers or nebulizers. Atomizers are commonly used for applying the local anesthetic to the airway. The atomizer reservoir is filled with 2 to 4% lidocaine, and an oxygen tubing is connected from the atomizer to an oxygen source, and a high flow of oxygen is delivered to the atomizer. Nebulizers are frequently used to topicalize the airway. The major advantage of the nebulizer is its simplicity and lack of discomfort to the patient, and very little working knowledge of the anatomy of the region is required. Mouthpiece type nebulizers are used to topicalize the oropharynx and the trachea. A face mask type nebulizer can be used to topicalize the nasal cavity, and the patient is instructed to breathe in through the nose. Commonly, 4% lidocaine is used as a standard nebulizer solution. The local anesthetic is added to the standard nebulizer with a mouthpiece or a face mask with high oxygen flows. The patient is asked to inhale the local anesthetic deeply for approximately 15 to 30 minutes. This achieves a reasonably good level of topical anesthesia throughout the oropharynx and the trachea. Disadvantages of aerosolized local anesthetic include a highly variable density of anesthesia, and patients may still experience an intact cough reflex. The rate of onset of the block is highly dependent on patient compliance. Many patients who need an awake intubation may be unable or unwilling to take deep breaths. Inhalation of the local anesthetic vapor can lead to central nervous system toxicity in patients with altered mental status. Spray as you go is another technique used to topicalize the airway. This is a non-invasive technique and involves injecting local anesthetic through the suction port of the fiber optic bronchoscope. The targeted areas are sprayed with aliquots of 0.2 to 1 ml of 2 to 4% lidocaine. It is essential to wait for about 30 to 60 seconds before advancing the bronchoscope to deeper structures, and the maneuver may have to be repeated frequently. To perform nerve blocks for awake fiber optic intubation, one must determine the structures that need to be anesthetized along the two basic routes of intubation. which is oral or nasal. Each of these routes have well-defined pattern of innervation that can be specifically blocked to provide adequate anesthesia. The airway is innervated by the trigeminal, glossopharyngeal, and vagus and their branches. The nasal passage and the nasopharynx are innervated by the trigeminal nerve. The anterior one-third of the nares is innervated by the anterior ethmoidal nerve, and the posterior two-thirds of the nare is innervated by the greater and lesser palatine nerves. The oropharynx is innervated by the branches of the vagus, facial, and the glossopharyngeal nerves. The three branches of the glossopharyngeal nerve provide sensory innervation to the posterior third of the tongue, the vallecula, the anterior surface of the epiglottis, the walls of the pharynx, and the tonsils. The sensory innervation of the anterior two-thirds of the tongue is provided by the lingual branch of the mandibular division of the trigeminal nerve. The larynx and trachea is innervated by the internal branch of the superior laryngeal nerve, which is a branch of the vagus nerve. The superior laryngeal nerve provides sensory innervation to the base of the tongue, posterior epiglottis, the epiglottic folds, and the arytenoids. The recurrent laryngeal nerve provides sensory innervation of the vocal cords and trachea and motor innervation to all the intrinsic laryngeal muscles except the cricothyroid, which is supplied by the external branch of the superior laryngeal nerve. The glossopharyngeal nerve provides innervation to the mouth and the oropharynx. Blocking the glossopharyngeal nerve blocks the gag reflex associated with instrumentation of the airway, as well as helps in facilitating the passage of the endotracheal tube through the posterior pharynx. The glossopharyngeal nerve travels anterior along the lateral surface of the pharynx, and its three branches provide sensory innervation to the posterior third of the tongue, the vallecula, the anterior surface of the epiglottis, the walls of the pharynx, and the tonsils. The glossopharyngeal nerve can be blocked using one of the three methods: topical spray application, direct mucosal contact of soaked pledgets, or direct infiltration by injection. The glossopharyngeal nerve can be accessed at the base of the palatoglossal arch. Lidocaine-soaked swabs are inserted along the tongue until they contact the base of the arch. Some patients will respond to this with a retch, which is a good indication that the pledget is in the correct position, and backing off will resolve the gag. Generally, the swab is re-advanced a few moments later, and the patient is asked to close their mouth with the swab and hold them in position for 5 to 10 minutes, and the procedure can be repeated on the opposite side. The glossopharyngeal nerve can also be blocked by direct infiltration by injection, and this can be done by either intraoral or extraoral approaches. Both approaches involve deposition of a local anesthetic in close proximity to the carotid artery. Therefore, care should be taken to aspirate and for a negative aspiration of blood. The superior laryngeal nerve is a branch of the vagus nerve. The internal branch of the superior laryngeal nerve supplies the posterior epiglottis to the vocal cords, and the external branch supplies the cricothyroid muscle. The superior laryngeal nerve can be blocked using soaked pledgets. After topicalization with a nebulizer, the patient is asked to stick the tongue out, and the tongue is then grasped using a gauze pad. The anesthetic soaked pledgets are placed in the pyriform fossa located on either side of the root of the tongue using a right-angled forceps. The pledgets are left for 5 to 10 minutes, and a sufficient degree of anesthesia should be present for intubation. For direct infiltration of the superior laryngeal nerve, it is necessary to identify the anatomical structures. The cricoid cartilage, the thyroid cartilage, and the hyoid bone, which is 1, 2, and 3 respectively, 4 respectively. Superior laryngeal nerve can be blocked in the neck using a 25 gauge needle. The needle is inserted in an anteromedial direction until the lateral aspect of the greater cornu of the hyoid bone is contacted. The needle is then walked downwards towards the midline of the inferior border of the greater cornu. The thyrohyoid membrane is then pierced and the internal branch is blocked. If the needle is retracted slightly after contacting the hyoid bone, both the internal and external branches of the superior laryngeal nerve are blocked. The syringe is aspirated, and if aspiration is negative for air and blood, 2 ml of local anesthetic with or without epinephrine is injected. In the event of aspiration of air or blood, the needle is retracted and the procedure is repeated again. The superior laryngeal nerve can also be approached in the preepiglottic space. The preepiglottic space is accessed at a point 2 cm lateral to the thyroid notch. The needle is advanced 1 to 1.5 cm superior posteriorly to pierce the thyrohyoid membrane, and the nerve can be injected. The trachea and vocal cords are innervated by the recurrent laryngeal nerve. The recurrent laryngeal nerve also provides motor innervation to all the intrinsic muscles of the larynx except the cricothyroid muscle. The sensory innervation of the trachea can be blocked by performing a transtracheal injection with the local anesthetic. The thyroid cartilage and the cricoid cartilage are identified, and the cricothyroid membrane is localized. A 25 gauge needle raises a small skin wheel, and a 20 gauge angiocath is used to perform the transtracheal injection. Sufficient blockade of the recurrent laryngeal nerve can often be accomplished using the inhalation technique. However, another technique for blocking the sensory input of the recurrent laryngeal nerve is to perform a transtracheal block. The cricothyroid membrane is located in the midline of the neck and can be located by palpating the thyroid prominence and the cricoid cartilage. A 20 gauge angiocath and a 20 gauge needle on a 10 ml syringe with 2 to 4 ml of 4% lidocaine is used to perform the block. The needle is introduced perpendicular to the axis of the trachea.
Can you talk to?
Perpendicular to the axis of the trachea. The needle is advanced until air is freely aspirated, signifying that the needle is now in the larynx. The local anesthetic is instilled, which results in coughing. This is a step-by-step summary of the orotracheal fiber-optic intubation using topical anesthesia only. Once the airway has been cleared of all the secretions using glycopyrrolate, 0.2 to 0.4 milligrams, and at least 20 to 30 minutes before the fiber-optic instrumentation, judicious sedation is provided and the dosage is titrated depending on the patient's comorbidities. Benzocaine spray is used to anesthetize the oral cavity and the posterior pharynx. 2 to 5% lidocaine ointment is applied on the oversapien airway and inserted, and the tip of the airway is inserted into the patient's mouth. As the lidocaine ointment dissolves, it is carried deeper into the pharynx and swallowed by the patient. The airway is then subsequently advanced deeper as tolerated by the patients every 2 to 3 minutes. Eventually, the patient should be able to swallow the entire airway without any discomfort. A 5 ml syringe is attached to the insufflating port of the flexible bronchoscope containing 4% lidocaine, and the bronchoscope is advanced until the epiglottis and vocal cords are seen. 2 ml of the local anesthetic is injected over the epiglottis, and the scope is advanced after 15 seconds. Additional 1 ml of the local anesthetic is injected when the tip of the scope is just above the vocal cords, and the scope is advanced again after a few seconds. Finally, 2 ml of the local anesthetic is injected through the scope through the vocal cords, and finally the scope, the fiber optic bronchoscope is advanced until the carina is seen. The endotracheal tube is advanced over the fiber optic bronchoscope, and the position of the endotracheal tube is confirmed, and the endotracheal tube is secured. Capnography is used to confirm the return of entitled CO2. If for any reason it is unable to intubate the patient using the topical method only, appropriate nerve blocks of individual nerves can be done to make the patient cooperative. The nasal fiber optic intubation. The nasal passages are supplied by the greater and lesser palatine nerves and the anterior ethmoid nerve. The greater and the lesser palatine nerves innervate the nasal turbinates and the posterior two-thirds of the nasal septum. The sensory input from these nerves can be blocked by topical application of the local anesthetic into the nasal passages. If topicalization proves inadequate, regional blockade of the palatine nerves can be accomplished by blocking the pterygopalatine ganglion. An oral approach to the pterygopalatine ganglion is described with needle passage through the greater palatine foramen into the pterygopalatine fossa. The anterior ethmoid nerve can selectively be blocked by direct mucosal contact application with an anesthetic-soaked cotton applicator passed along the dorsal surface of the nose until the anterior cribriform plate is reached. And the topicalization of the nose can be accomplished by use of cotton anesthetic-soaked cotton pledgets or swabs. These swabs or pledgets are soaked in aqueous or viscous local anesthetic solution and left for 5 to 15 minutes on the region of the mucosa that requires anesthesia. The cotton acts as a reservoir for the anesthetic agent, producing a dense block. Cocaine-soaked pledgets can also be used to topicalize the nasal passages. Epinephrine or phenylephrine can be added to lidocaine to promote vasoconstriction. Alternatively, oxymetazoline spray can be applied to the nasal mucosa to promote vasoconstriction before application of the local anesthetic. A step-by-step approach to nasal fiber optic intubation of the trachea under local anesthesia. A lubricated endotracheal tube larger than the diameter of the fiber optic bronchoscope is softened by placing it in warm water before use, as it is less likely to cause mucosal trauma or submucosal tunneling. The endotracheal tube is advanced through the nose into the pharynx by aiming perpendicular to the plane of the patient's face. If resistance is met at the back of the nasopharynx, 90 degrees of counterclockwise rotation allows the endotracheal tube to pass less traumatically as the bevel faces the posterior pharyngeal wall. The fiber optic bronchoscope and the endotracheal tube are manipulated to bring the larynx into view, and the bronchoscope is advanced into the trachea. The target should always be kept in the center of the field of vision by flexion and rotation as the fiber optic bronchoscope is slowly advanced. As the bronchoscope passes through the vocal cords, the tracheal rings will become visible. The scope is then just advanced just above the carina, and the endotracheal tube is threaded over the bronchoscope. Any resistance to advancement often means that the endotracheal tube is impacted on the arytenoids or the vocal cords. This can be relieved by counterclockwise rotation of the endotracheal tube as it is gently advanced. The appropriate depth of the endotracheal tube can be verified by observing the distance between the carina and the tip of the endotracheal tube as the fiber optic bronchoscope is withdrawn. The position is confirmed and the return of the entitled CO2 is confirmed. The patient is anesthetized after confirmation of the correct placement of the endotracheal tube and the return of the entitled CO2. This concludes the talk on preparation and management of a known difficult airway in adults. Thank you.